Thanks, Allison. Thank you, Allison. And I'm really glad that everybody has joined. I'm just going to give a very brief intro about ACEs Connection. I'm a staff reporter here at ACEs Connection. I'm also the community manager for ACEs and Pediatrics. And we have more than 47,000 people who are working on ACEs initiatives across the country and internationally to change trauma-inducing systems into systems that are responsive to trauma and build resilience. So I just wanted to give a little bit of background about what's going on in California, because that's partly what precipitated this meeting. And at the beginning of the year, California began rolling out ACEs screening of its pediatric population using the PEARL screener, which stands for Pediatric ACEs and Related Life Events. It's being rolled out first among the Medicaid population in California. It's voluntary for families to answer the questions, which were vetted by focus groups of patients. The PEARL screener includes questions about abuse and neglect, and also questions about whether a child has experienced discrimination based on race or gender. It also asks about whether families have faced hunger, eviction, among other questions about basic survival. There's more background about it that I'm going to put into the chat now, including that trauma-informed trainings for more than 150 sites are now underway in California. And the link that I'm putting in also gives you more detailed, it's the actual landing page that I used, I sent out for people to register. It also includes more detailed descriptions of our panelists, which I'm so thrilled that they've joined. So let me just talk a little bit about the idea for this webinar. It arose really from conversations among the community facilitators at ACEs Connection around universal ACEs screening and concerns that they were hearing in communities wanting to know about how ACEs screening is carried out, and a general feeling of mistrust about it based on the historical treatment of people of color by medical systems. So I also want to thank my colleague Ingrid Cockhren, who helped me conceptualize this webinar, and she's also going to be speaking very soon. And Sissy White and Danielle Prince were also among those who provided feedback from their communities. So Ingrid is our first speaker. She's ACEs Connection's Midwest facilitator, and she's going to speak about the history of racism in medicine, and she can tell you more about her work on equity and inclusion. Ingrid.
Thank you, Laurie. Again, my name is Ingrid Cockhren. I always give a disclaimer in this virtual world that I have a big dog and a 2-year-old, so you might hear them. But I wanted to really help to frame this conversation along the lines of the historical context when it comes to interventions in general and assessments in general, not just medical, but also education, and also the child welfare system, and because that is also an element to think of as we think about assessing children along the lines of trauma. So historically, ACEs science is no different than other types of new interventions and new understandings of human development, and the application of new science has always been a source of distrust for people of color. And this is no different when we think about what it means to assess people and assign any type of judgment that goes along with that assessment. When we look historically at the field of medicine, at the field of education, people of color, no matter the outcomes of data that is collected, they experience inequity. And so I want to give some examples. When I work with hospitals and pediatricians, we often have conversations around what does it really mean to say that people of color have a different culture, and we need to acknowledge their cultural differences when it comes to medicine and interactions and assessments? And one thing that I think that people do not understand is that in the past, we have used data and research against people of color as a weapon. And we need to move forward with that understanding and actively push to not do so in the future. And so let me give some examples of what that looks like. I recently had a conversation with some pediatricians about what we call wimpy white boy syndrome, which is a phenomenon that has been determined that infants who are born early, when we look at demographics, white male infants who are born early tend to have worse outcomes. And then Black girl infants who are born earlier tend to have better outcomes. And what does that mean for the field? This is something that you would think is an indication of a protective factor, and yet it could also be seen as an issue of who gets care, right? And so because I know this data, am I going to be giving more care and attention to the white males that are in the NICU versus am I going to give less care and attention to the Black girls that are in the NICU? And so this is a good example of how our understanding of outcomes, data, assessments doesn't exactly mean that we are going to be able to be equitable in our treatment. And we also have to understand that when we look at data, that we're looking at data through the lens of our own personal bias. And we're looking through data through the lens of historical context as well. I'll give another example. After slaves were freed and we were moving into Reconstruction, the slaves were dying off at a large rate. And that's mainly because during slavery, they had food to eat, they had places to live, they had shelter. They were being cared for by their owners, their slave masters. And once they were no longer slaves, they were not given shelter and food and things of this nature. And there was a national debate as to should the US government become involved in caring for these freed slaves. And they justified their lack of care, or the substandard response to the health outcomes of those freed slaves by saying that the Black people were inferior, and thus maybe the US government should not take care of these freed slaves because it was a kind of divine order. And how much effort should the US government, effort and money, should the US government put into protecting or saving these freed slaves from just regular basic issues of infectious disease and not having enough food and being exposed to the elements. This is an example of how despite there being great medical minds at the time, some of the greatest medical minds at the time in the world, looking at this issue, they were biased because of the social political climate. They were unable to see that, of course, any group that has not been able to take care of themselves, has not learned how to be free, is going to struggle with health outcomes if they are suddenly set free without any type of safety net. Instead of seeing their suffering as a normal part of the human condition, it was seen as a supporting, or what we call a confirmation of their bias, which was that Black people were inferior physically and could not make it without the help of white men. And so this is the historical context that we have. And we need to understand that as we look at data, no matter what it is, we have to understand that we have to see it from our own bias in the historical context. ACEs is a perfect example of that. Right now, the data is very clear that people of color, particularly African Americans, indigenous families, and Latinx communities are experiencing complex trauma, 3 or more ACEs. So what does that mean? Well, when I first got into this field of study, when I was in grad school, or the reason why I went to grad school was to get more understanding of why I had more African-American children in the division of juvenile justice that I was working in than any other race. I went in and I looked at the data and I looked at the families, and then also I knew those families because I'm also from that community. And yet still I had a white supremacist lens on when I was looking at what was happening with these families. And to me, I thought, well, this is a parenting issue. These parents are not good parents. They're doing a poor job of parenting, and that's why there's so many African American children in juvenile justice. So then I went to grad school to study African American parenting practices, and then I was able to kind of take off that white supremacist lens and have a better understanding that these parents were parenting based on their history and parenting in a way that they believe was promoting the survival of their children in a racist society and what that looks like. So when we think about physical punishment, which the research shows that African-American families, African-American children are more likely to be physically punished. And we're thinking, okay, well, it might be stress. It might be that these families are experiencing high levels of stress, and so they are using physical punishment more because of that. And that is an element of it. But also, you have to think about the parenting practices of slaves. What type of parenting practices would slaves use? And then think about how we parent the way that we are parented. And if we go back just 5 and 6 generations, then we're talking about people who are parenting during slavery. And you would have to be a very strict parent for you to instill some survival skills into your child when the stakes are so high. When if they flirt with the wrong child or look at the wrong person in the eye, that it could be life or death for them. And so you have to think about what that means for parents. And the wide historical view of this is important, because as you think about when we do ACEs assessments, when that pediatrician is interacting with those families, do they think about that history? Do they want to connect with them along the lines of, how are you dealing with racism? How is your family dealing with the stress of racism? How is your parenting being impacted by racism? And if they're leaving that out, then when they do that assessment, or when they get information, or when they look at data, they're going to look at it through a white supremacist view, which is something that all of us are getting from our environment, not just white pediatricians, but everybody is getting this from the environment. And this has led to what we would call Jane Crow, which is a very systematic separation of Black children from Black mothers through the child welfare system, as people are referring those families to child welfare for less offenses than they would for white families. So even if white families are displaying the same behaviors within the same context, within the same social economic status, Black families are more likely to be referred to child welfare. And so Jane Crow, which is a period that came after Jim Crow, which ended in the 70s, Jane Crow started in the 80s with the crack epidemic. And it led to tens of thousands of Black children being separated from their families, from mothers who were either suffering from addiction or they were dealing with just poverty. And when we think about that, we have to understand that that separation is just a continuation of a historical context where America is totally fine with separating Black children from their families. That has always been the case. It is more prevalent, and it has been the case throughout our entire history. And so we have to think about what it means when we do these types of assessments. When we're looking at this data through our bias lens, how will we protect those families? So if we're going to assess and we're going to be taking this data, what will we do with it? How will we protect families of color from the implications or the bias that exists in our society? And also really taking in the historical context of what does it mean when we say that certain groups are experiencing more ACEs? Are we going to look within those families and say this is an issue within the family dynamics? They need X, Y, and Z, or are we going to say the system is broken? That the racist country that we live in is impacting certain families more than others. And are we going to attribute that data and the findings from it to the larger system as opposed to individual families?
Thank you, Ingrid. That brings up a lot of questions, and I want everybody to put your comments, continue putting your comments and questions into the chat. We'll have everybody speak, and then we will have the question and answer period. So I also wanted to know before, oops, there's my timer. I also wanted to know before we continue, how many people who are participating in this meeting have experience with ACEs screening in one way or another? And if you could just sort of write in what your experience has been, that would be interesting to know. So our next speaker is Dr. R.J. Gillespie. He's a pediatrician with the Children's Clinic in Portland, Oregon. Nationally, he was an early adopter of ACEs screening. He will discuss why, wait a minute, sorry, I just need to, I had my, he's going to talk about why he chose to screen parents, and then what he does to build trust. And he will also tell you more about his background. Thank you, Dr. Gillespie.
Hi, everybody. I really appreciate the opportunity to talk today. And as Laurie said, my main focus has been on screening parents for their adverse childhood experiences. And I think, you know, over the last almost 8 years since we started doing this, I've learned a lot about what not to do when it comes to screening and how you have the conversations. I'm certainly not an expert in equity. I am definitely a novice in that. And still doing my level best to try to learn what I can. But I think that hopefully I'll give you some ideas about how to build trust and to hopefully create a little bit of equity while you're doing this kind of screening. So a little bit of background about why we decided to start with parent ACE assessments as our approach when we started this back in 2013. In my practice, we're 30 providers in 3 practice sites. And we've been, for a long time, really trying to work hard at early childhood development and developmental promotion. And that really started with some of our standardized universal screening protocols that started in 2008 with developmental delay in autism. The following year, we started working on maternal depression. And then a couple of years later, started working on adolescent depression and substance abuse. All that to say that we were fairly familiar with how to do screening as far as workflows and office systems go, but we hadn't really approached the idea of trauma. But as pediatricians, we're all about prevention. We wanted to see what we could do to try to ultimately prevent ACEs from happening in the first place. And for that, we wanted to get as far upstream as possible. When we look in the literature, there are a couple of stories that I kind of cling to in terms of why I think parent trauma in particular is important. The first is that there are pretty clear correlations between parent ACE scores and the child's eventual ACE score. So the more ACEs a parent has experienced, the more ACEs the child is likely to experience. That's not to say that that's linear. Somebody who's physically abused doesn't become a physical abuser themselves, but they may suffer from mental health problems or relationship problems or other things that will become ACEs for the next generation. But certainly the families with high ACEs tend to have kids with high ACEs ultimately as well. We know, though, from the psychology literature that parenting styles are at least in part inherited, so that if a parent did experience harsh parenting styles, they're more likely to engage in those styles themselves. I think this comes down primarily to modeling. So our biggest role model of how to be a parent comes from how our parents treated us. So if that was a particularly harsh or difficult experience, these parents may not have ideas about how to engage with their kids in a way that is different and perhaps healthier. We also know, and this is neuroplasticity data from University of Denver. When I was in medical school, I was taught that by the age of 3, you pretty much have all the brain tissue you're ever going to have. We know that's not true. And this series of studies done by Pil-Young Kim showed that new parents actually have new brain growth in the first 6 months after their kid's born in both the amygdala, which is the emotional center, and the frontal cortex, which is the logical center, presumably keeping those two things in balance so that your frontal cortex would be able to regulate your emotions to some degree. And both those areas of the brain develop unless they're experiencing extreme stresses in the first 6 months, which impairs the frontal cortex development, in which case you have an emotionally reactive brain without the ability to control it. Which we think may lead to harsh parenting styles as well. And those types of stressors that they're talking about are things like intimate partner violence and food and housing insecurity and things like that. We also know that kids that have experienced 3 or more ACEs before kindergarten have worse readiness scores. So not only are their literacy, language, and math skills lower, but their rates of behavioral problems are higher. And I always pause at that just to say 3 or more ACEs before entering kindergarten, just to remind people that when ACEs are happening, they're happening to very young children, right? So to have 3 ACEs already by the time you're 5, that's a big deal. And what we thought when we started this assessment process is that if we could help identify parents who might be at greater risk, bring their trauma histories out of the closet and agree to support them when they feel most challenged in a non-judgmental way, that perhaps we'd be able to create a new cycle of healthier parenting. I don't personally have kids. I'm told that it's stressful, but there are certain times in a child's life that are more stressful. And certainly some of the normal toddler phases, like going through tantrums, if you have problems with colic, toilet training resistance, when they kind of do their natural thing, biting and things like that, or having sleep problems, these are examples that might be more stressful in particular. And if a parent has had trauma, is that going to trigger their fight, flight, or freeze response when their kid yells at them or hits them or has these other kinds of normal toddler behaviors? And can we actually help parents to have a different reaction? So how do we better prepare our at-risk parents for these inevitable moments? And even further, if a parent's experienced trauma, they often, I don't think, have good ideas about how to do good self-care, how to identify when they need help and to reach out to people for that kind of support, how to model appropriate conflict resolution within their own relationships, how to do discipline that's developmentally appropriate. And in some cases, they may not even have ideas about how to play with their children. And so in other words, we wanted to try to figure out how we actually teach parents and children to be more resilient. And that was really our primary focus and purpose when we started this screening. And we found pretty quickly, just in looking at our own data, that there was a big correlation between parent ACEs and their kids' developmental screening scores, so that by 2, the kids were more likely to have developmental differences that we could detect on ages and stages questionnaire. And that happened even with a single maternal ACE. This is a graph that is meant to display sort of the relationship that we measured, so that if you get out to 10 ACEs, that about 3/4 of those kids would end up failing their developmental screen by 2. So pretty strong correlations there. That said, I think that we've learned a lot more about how to interact with families in these kinds of situations that go beyond just doing the assessment tool itself. And so that's what I really wanted to primarily talk about today. And I think in simplest terms, in order to really build trust with your families, you really need to have a laser focus on your own mindset and your goals for conducting the assessments. One of the comments that came out fairly early in my commentary that I put in ACEs Connections was about the idea of labeling kids. And certainly that's a concern because when you do the ACE screening in California, my understanding is then that ACE score is reported by a CPT code to Medicaid. And certainly I think that that is the last thing that we're called to do, is really to label people based on what their ACE scores are. I think it's also we're not called to do ACE assessments just to obtain payment. We're not doing it out of personal interest. This isn't and I'm so cool because I'm doing trauma-informed care kind of a thing, that it has to be something beyond our own personal interest, and really figure out how to support our families in a way that is non-judgmental. Now, these are some slides that came up in my very first trauma-informed care training, and I think it sort of drives home the point of one of the major essences of trauma-informed care. So when you look at these two pictures, the two kids on the left and on the right, it's unlikely that people would make a lot of judgments about these kids, although I think that probably does happen, that there are perhaps assumptions or judgments that we make about the two kids, what their families are like, what their potential is. When we look at these two women, we make a whole different series of judgments about those two people. And what trauma-informed care really asks us to do is to stop asking the question of what's wrong with this person and start asking the question, what happened to this person? And then to take the next step of how can I help you? And this really gets down to, this is a Buddhist principle called radical acceptance, that whoever comes into your office, no matter what they look like or how different they may be from you, that this is our call, is to look at every family as having potential and as having value and as having experiences that perhaps we need to know about in order to help them. I think that for me, one of the primary lessons that I've learned in doing ACE assessments for families is that success in our conversations about ACEs is about building the relationship, and it's a relational success. So my goal is never to force a disclosure. A parent always has the right to say to me, I'm not answering these questions, or I don't want to answer these questions, and that is perfectly fine. And I'm glad when people have those kinds of conversations, that they're not ready to talk about this. What I want to have happen, though, is I want my office to be a safe place for people to be able to talk about whatever challenges they're facing. And that, to me, is more the success in doing these sorts of assessments, is if I've given the family a message that I care about them and that I'm here to help them. That to me has been, again, the biggest definition of success. I think that's played out for me in multiple visits after I've done an original ACE assessment, where a parent has come back to me and revealed something like domestic violence spontaneously, or they've told me about food insecurity problems that they're having, or problems that they're having with their finances. So that the family has, again, gotten the message that I'm here to help them, and that this is the primary goal. I think, too, that the way that we have our conversations about ACEs, first of all, we need to suspend what's referred to in motivational interviewing as the righting reflex. So we have this tendency as providers to want to try to fix whatever's in front of us. That our job, if the ship is listing one direction or the other, is to right the ship. And if we're doing that, that means that when somebody's disclosing trauma to us, we're not paying attention to the story, because we're already working out in our heads what we're going to do for that family and what our plan is. And so we're not actually being present and listening. And that really makes the conversation distracted, and it makes it unsafe for the person who is doing the disclosure. I think, too, that one of the things that I saw early on when in my career in quality improvement, I started with developmental screening training and teaching providers how to do developmental screening. And I would frequently see that providers would collect their developmental screening tools and have them in a pile that they would go through at the end of the day as they're doing their charts, which meant that they didn't have a conversation at the point of care with the family about the developmental screening tool. I think this is an absolute, you cannot do this when it comes to assessments for ACEs, because, again, what you've done is you've created a message of silence, which says that the disclosure is not safe, because or that you think the conversation is not important. So I think regardless of what the assessment tool says, that you have a conversation with every single family about trauma, about resilience, about your goals in terms of asking the questions, and then give them a chance to disclose or not disclose. But you don't wait till the end of the day. You don't try to call them back later after the assessment tool has been reviewed or whatever when you're charting. You have to do it every time with every family. And I think that when we change our mindsets to the idea of what, instead of what's wrong with this person, what happened to this person and how can I help, we start making more sense out of patients' and parents' behaviors if we understand where they're coming from. I think that when it comes to creating a culture of safety, there's some data that I have always found very interesting. One is that positive relationships with providers matter for building resilience. So kids who have 2 or more ACEs whose parents report that their child's healthcare provider always listens, spends needed time, and gives needed information are 1.5 times more likely to live in families that practice basic resilience skills. And children whose parents report always having positive communication with their child's healthcare providers are over 1.5 times more likely to practice 3 or more out of 5 recommended protective family routines and habits. Things like reading daily with your kid, having a bedtime routine, things like that. This comes from the National Survey of Children's Health. And I always like this data because really this is validating the importance of the relationship that we have with our families. And this is really talking about spending time and listening to our families in a way that is supportive and meaningful and positive. My personal approach when I do have an assessment tool that I'm going over, if there's a disclosure, then I think it's important to start by thanking the patient or parent for opening up about their experiences. This validates the importance of the conversation. It really recognizes that it's a difficult thing sometimes for parents and families to talk about. And then I always ask these same 3 questions. The first is to get immediately at safety. So if there's any particular issues that the family needs to deal with right now, and are any of these experiences that still bother you now? The second question to me is about resilience. So those that don't bother you, how did you get to the point that they don't bother you anymore? So that I can start talking to the family about what factors in resilience they have or that they might need to build so that we can have the flip conversation so it's not all about trauma. And then how do you think these experiences affect you now is my next question, to try to help people start thinking about how their past experiences may help with may help them understand how they react to their kids in terms of their current parenting. So I think that approach to screening, it should be universal and free of judgment. So we're not making assumptions about who has ACEs or who doesn't have ACEs. So we're only giving the screening tool to people that we think have ACEs. It really has to be a universal thing. Otherwise, we are making judgments about our families and our patients. It should be compassionate and it should really be approached with humility. As I said, my personal goal is to create a culture of safety and mutual learning and to offer myself as a partner in my patient's health. I think that beyond that, screening tools really need to be thought about a little bit differently. I think that when it comes to all the different screening tools that primary care providers are asked to do, they become almost a sort of checklist where, if we're supposed to do maternal depression screening at certain intervals and developmental screening at certain intervals, autism screening at certain intervals, and then you add in things like social emotional development, ACEs, social determinants of health, and other things like that, it becomes simply a pass, fail, refer, observe, and then move on. But I think we really need to think about how these screening tools relate to each other and help us to really understand the context that the kid is growing up in. And so for me, if I take the background of developmental health and then I overlay these different screening tools onto developmental health, I'm going to have a much different workflow as a clinician if there are parental ACEs and developmental delays, or if there's maternal depression and developmental delays, or social determinants and developmental delays. Those result in different kinds of responses as a clinician. And so seeing how these different screening tools relate to each other helps us to create a better plan for our families and really ultimately have a better understanding of social emotional health and how social emotional health is really probably the most key factor in terms of kindergarten readiness and lifelong success ultimately. As I mentioned, I think that screening tools are oftentimes thought about just assessing risk and connecting to resources without sort of an opportunity to integrate those things and see how they relate to each other. But also I think that screening tools need to become a teachable moment and an opportunity for education. So if I'm using my screening tool to also help families understand trauma and to understand the effects of trauma on health, then that's a better purpose for that screening tool. And this is a slide that comes from Andy Gardner and his book, Thinking Developmentally, which talks about a public health approach to trauma. And at the bottom, the baseline primary type of prevention is really about universal prevention, so that everybody gets some messages about anticipatory guidance around trauma and the effects of trauma. Everybody gets some positive parenting and other developmental promotion activities. Then the ACE questionnaires become a secondary intervention in terms of trying to figure out who needs more from us, who needs an extra boost from us. So when we start looking at things like parent ACEs or child ACEs, social determinants of health, and other things that might be getting in the way of healthy development, then we can do a further assessment to figure out which kids need, have symptoms related to toxic stress, and then connect them with appropriate resources. And so the way that breaks down for me is that the ACE assessment, first of all, becomes an opportunity to provide that universal education about trauma and resilience. It also helps me to understand who may be at risk and therefore get extra help from me in terms of positive parenting, relational, and attachment repair and other interventions. And then also to help me understand who might have trauma symptoms and then need something further, like parent-child interactive therapy or attachment behavioral, biobehavioral catch-up or things like that, so that the ACE assessment serves a role in all three of these different levels of health. And to me, I think that it's important to kind of think beyond our medical model too, in terms of who's on our side and who's going to help us with families when we do identify trauma. I think there's a tendency to think about if you have trauma, you need a mental health provider or you need a counselor. And I think it goes far beyond that, that there are public health interventions that are helpful as well. We know that nurse-family partnerships and other home visiting programs can help to reduce child abuse. This is really, to me, one of the big equity questions, though, that comes out, is that many communities see nurse visitation programs as spying on their kids and spying in their house. And so there's an inherent distrust in these kinds of programs. So even though they're helpful, they're not often accepted. And so this is something I think we need to really work on as a system, is how to make these programs sensitive to those kinds of perceptions about them, and how to actually help families get services that might be useful. There are community referral agencies in many communities that also can help to connect families to culturally sensitive or specific services. So 211 Info and Help Me Grow are two of the primary models. I would personally love to see early intervention and early childhood special education take on a bigger role in this. The parent coaching model really is meant to improve interactions between parents and kids. And so some states have looked at family risk factors as being reasons to qualify for early intervention. So for example, Illinois treats maternal depression as a qualifying diagnosis. I think it would be fantastic to see trauma as one of those qualifying diagnoses, because really that parent coaching model should help with attachment and an attunement between the parent and the child. Other mother-baby diet interventions, and there's a list of those coming up on the next slide that I won't read to you, but I think also thinking about mentoring programs and how you create connection for kids. So again, just thinking beyond what medical homes and what primary care providers can provide. This is the list of parenting interventions that have good evidence. So these are the types of programs that I would love to see people who do ACE assessments actually get connected with and find in your community, so that you can actually help. And so to me, I think that with everything that we know about ACEs and everything that we know about trauma and its effects on health and wellness, the assessment tools that we do need to go beyond just a simple identification role. And we really need to figure out how to help these families who've experienced trauma connect to appropriate services. I think that primary care with mental health colleagues can actually work on mental health prevention using ACE information. And so I think that that's an important factor to think about. I think that mental health also can help us in supporting social emotional development. And I think that in terms of kindergarten readiness, we need to think about that as a cross-sector, multidisciplinary effort that really engages all community partners. So again, moving beyond just an assessment, is it there or is it not, but really thinking about a robust approach to responding to these families is where we need to go as a community. Ultimately, to me, I think the outcome that we want to come to is how we use our knowledge of ACEs in children and parents to prevent ACEs in the next generation, and also to support and promote kindergarten readiness. I know this is a tall order, but I love this, this analogy that was told to me by a friend in college, actually years and years ago, but it's something that I've had stuck in my mind ever since, because I think when it comes to thinking about the whole of trauma and ACEs and what we need to change as a society, it becomes overwhelming to think about, and it seems like just absolutely more than we can manage. But when it comes to moving mountains, there are forces in nature that can move a mountain, and that's a glacier, right? So glaciers move mountains, and they are formed by snowpack, and snowpack is formed by snowflakes, one at a time, falling in just the right place. There have been some not very nice things said about snowflakes by certain people in our political community over the last few years, so I'm taking the opportunity to reclaim the term snowflake and to say that I am very proudly a snowflake, being the one person falling in just the right place and hopefully helping to build a glacier with all the rest of you. And that's what I had. So thank you for the opportunity.
Thank you. Thanks so much. Okay, well, I want to also say, let's see, that again, I want to invite everybody to put questions into the chat box and any comments that you have. And I want to go right to our next speaker. And I also want to say, and this is my fault, I was trying to cue you and I couldn't properly. So I think what I might do is I'm going to put a little note to you when you have 2 minutes left to go, so you know. And I will do it that way, just to be sure. So with that, thank you so much. That was really full and rich. And will these slides be available? Can we make those available after? Okay, great. So our next speaker is Dr. Shandi Fuller. She's a pediatrician and the Deputy Health Officer, Maternal Child Adolescent Health Consultant for Solano County, California. She has worked for the Solano County Family Health Services since 2012 and oversaw the training and implementation of a pilot on ACEs screening among patients and adults without children in a safety net clinic in Vacaville. Dr. Fuller will talk about the in-depth equity training she and a colleague developed for medical providers. But I wonder if you could start just how that came to be, because you told me about that when I wrote a story about the clinic, which I'll also put in the chat. Thank you.
Great, yes. So I just want to thank you for having me. I always love coming to things like this. I always leave with more knowledge than I came with. And I have one slide. I'm not sure if I'm going to show it or not, but I'm going to, instead of showing slides, just give you a story of how my trainings got developed and give you a little bit of back history on that, as well as a little bit of lessons learned and some of my thoughts of what's needed to move forward. So as mentioned, I work in public health. I'm Deputy Health Officer. And even though I've only been in public health for about 3 years, my entire work has always been focused on public health. But I got really involved in ACEs one day when one of our public health nurses came knocking on my door, and she was like, "You have got to see this documentary. It's called Resilience, the Biology of Stress and the Science of Hope." And so she was so excited about it. She had gotten a copy of it before it had gotten released, and so she let me watch it. And I thought it was so profound and that it was so on target for what we all kind of already knew about stress and toxic stress, but didn't have like the terminology and the science behind it. And so after watching that documentary, we started having screenings within public health all throughout the department, all throughout the county, and it became pretty clear to me very early on that this was definitely needed in our family health services clinics, in our medical clinics, pediatrics and adults. And, but one of the things that I thought was maybe lacking, or at least not explicitly stated, was that how racism is a part of ACEs. And what I mean by that is that racism is a form of trauma. And it traumatizes on every level, from the individual level to community level to a systems level. And, you know, if you don't specifically speak on that or look for that, or as Ingrid gave a really good, you know, groundwork about the historical significance of some of the things that we're seeing today. And if you leave out systemic racism from the conversation, then you're missing a big part of the conversation. And so when I thought about bringing, you know, this ACEs documentary and the concept of ACEs to our clinics, I definitely wanted that to be a big piece of it. Also, I live in Solano, well, I work in Solano County, and Solano County has been referred to as one of the most diverse counties in the country, if you look at our demographics. And what I say to that is, just because we're diverse doesn't mean that we don't have inequities, just like everywhere else. And if you look at our health outcomes, it's the same. We have health disparities in all of our social determinants of health, and many of our health markers. You see big gaps of disparities, especially when you separate out by race. So fast forward then, a few months later, we have an internal race equity team that had gone through trainings through this organization called GARE, and GARE stands for Government Alliance on Race and Equity. And so GARE developed a training which our staff in the county took so that they could bring back a version of race equity training back to the county. And so I thought this was a perfect opportunity to introduce this topic, and we were having a town hall meeting. So during our town hall meetings, it's staffed with doctors, nurses, front office, back office staff. Everyone meets during this town hall. And so I invited our race equity team to give this GARE training. And so when they came to town hall, they posted up on the big screen the PowerPoint and had the title, GARE Race Equity Government Alliance for Race and Equity. And kid you not, we could not get beyond the first screen, that first PowerPoint, that first slide, before someone stood up and was like, why are we talking about this? There's no need to talk about this. We're medical professionals. Why are we bringing this up? And so our moderators did a very good job of, you know, explaining the need for this, and that, you know, this is about equity. It's not just about government. And they proceeded to kind of give like little, what I call highlights of the training. We didn't give the full training, but we gave little highlights of the training, and which people participated in. But the one thing about the GARE training is that it's very broad. And so when I left that town hall, I realized that we needed to answer the question, why are you giving this training? And the answer to me was very clear, you know, but it may not be as clear to other people that systemic racism exists in medical care. And so what I did was I came back and I worked with a colleague of mine, and I was like, okay, well, we need to revamp this training so that when people leave this training, they have no excuse to not know why this training is needed. Now, they don't know, that's because they don't want to know, but we need to make specific examples for medical care providers and providers who work for children in general of why this is needed. And so we went back and I developed a historical trauma training, which goes through history from slavery to present day, about the effects that slavery has had on our health outcomes with Black people and Indigenous people, and even Latinx people. And one thing I realized about when I was giving these trainings is that in our society, we have very different understandings of history, and that history is taught very differently depending on where you live. But in all, there's only little pieces of history that we're given, and we're never really told the whole story. And because of that, it leads to, a lot of ignorance, and which then fuels our own biases. And so when I started doing these trainings for people, just talking about history, it was like an enlightenment moment for a lot of people, because they just really didn't know. And so we went back, so we did that training, and then we went back to our race equity training. And what we did there was we worked within a framework of GARE's framework for equity, which is you normalize the conversation, then you organize, and then you operationalize. And so the trainings that we give was just the normalized piece. And what we did with that is that we laid down definitions, because it's very important that you have clear, what you're speaking of, that you're talking the same language, and you understand the definitions. And so really that was what we worked with for the first training, was just an hour of like, what is implicit bias? What is structural racism? All of those terminology, which people really didn't know. And then we also had to pare down the training so that we can fit it into a busy clinic's schedule. So we went from a 4-hour GARE training to a 1-hour, okay, these are definitions. And then also what's important is that when you are learning about systemic racism didn't happen overnight. It wasn't something that just came in place like, 50 years ago, 100 years ago. We're talking about centuries of systems that have been put in place, and centuries of misinformation that's been given by groups of people that we a lot of times aren't even aware of the messages that were being received. Someone described it as like walking through a fog. It's like you're inundated with things from the media, from music, from just what you see. And just like as Dr. Gillespie showed that in his PowerPoint, the images of the babies, the black and the white baby, and then the two women. And immediately what happens is you get these thoughts that come into your mind, whether you're conscious of it or not. And that happens for all of us. Everyone has a bias. And it's almost like, it's like a knee-jerk reaction, that you have this. But if you're not in tune to those thoughts, then they can manifest in ways in your actions. And so it's really important to, early on to do an implicit bias training so that it brings more awareness to what you're thinking and what you've been taught to think. And so one of the components is the IAT, which Harvard has put out. It stands for the Implicit Association Test. If you're not familiar with that, you can just Google IAT, and I would encourage all of you to take it. There's many different, there's many different tests on there. Some of them are related to race, some of them are related to gender, and there's a whole bunch of different ones that you can take. But I've taken it several times, and you actually may be surprised about the results that you get. So basically, the test is to see if you're biased one way or another by that certain, category. And then at the end, it gives you a result. And it's something that Harvard has been using for a while. But like I said, you may be surprised, that you actually have a bias in one area. I know a lot of my colleagues took it, and they were like really shocked when they got back the results. But again, it's something that if you're not aware of, then you can't move forward from. So we spend a lot of time on that. And then what we also do is a lot of interactive, pieces, and where we give like scenarios. So again, answering that question, what does this have to do with me, right, is what basically they're saying. So one of our trainings is for specifically for Black women and Black infants, because in this country, the Black infant mortality rate is extremely high. Black infants are dying at twice the rate of white infants. And that is been going on for a long time. And it's information that's appalling and needs to be addressed, but not many people actually really know about it. And so what we did was we took that information to OBGYNs and Kaiser. And we showed them a video of a man named Charles Johnson. If you're familiar with like daytime TV, you may know Judge Hatchett. So Judge Hatchett has a son named Charles, and he had a wife named Kira. And so this is a man whose mother is a judge, not just a judge, but a famous judge. It's a Black family, okay? And his wife goes into labor. This is their second child. She has a C-section. Shortly after C-section, they both know there's something's wrong, okay? And they try to get attention, get medical intervention. Now, they're still in the hospital at this time. And as hours go by, she starts to feel colder. She starts to get worse. And finally, the doctor comes in, takes her back into the operating room, opens up. She had had a C-section, opens her up, and she pretty much bleeds to death right there. So there were signs that something was wrong. You have an advocate, in the room, who is a lawyer himself, so he can advocate. And he has a famous mother. This is not a poor family. This is not an uneducated family. This is not even a single mom in there by herself. And the reason why I say those things is because a lot of times, one, when we look at inequities, we end up victim blaming and pointing fingers and pointing shame. In fact, there was a media campaign in Florida when this information about Black infants came out, and their media was blaming Black women for the cause of them having their babies die before their first year of birth. So the other reason why I bring this out is because if you take all of those factors away, education, money, all of that stuff, and you compare a Black woman with a white woman, everything being equal, the outcome is still the same. So what does that tell us? Usually we think that if you have resources, if you have money, if you have this, like a long litany of things, then even if you're Black, you should be able to, overcome the odds. And what that shows us is that being Black in America, one, you are in a racist system, okay? And that trumps everything else. Also, the toxic stress of being Black in America is so high that it's one of the big factors why we're seeing a lot of these outcomes, a lot of these disproportionate rates in chronic diseases and such like that. So we see it multiple times. We see it again when Serena Williams goes into labor and she tries to advocate for herself, and she's like, come on now, like, you got to do something. Fortunately, she had, a healthy child and she's still alive. But then if you think, if these women have all of these assets or all of these resources, what happens to the woman who doesn't have someone in the room with them? Who, there may be a language barrier there, who is on, Medi-Cal or Medicaid, and that just compounds the issue even more. So we intentionally, anytime I do this, and I usually say this in the beginning, like before I tell the story, that is a trigger warning, but we usually give a trigger warning. We show the video. I also encourage you to look up the video on YouTube because it's very powerful to hear it spoken through his words. And then we go back to the OBGYNs. It's like, this is why we need to talk about this, because we hear this all the time from Black women. We are not being heard. And because we're not being heard, because we're not being valued, we're dying and our babies are dying. So, I also want to say to that point is that whenever you do a training, the training in itself is not enough. And what I was alluding to before is that this is a lifelong process. Systemic racism didn't happen overnight. It's not going to change overnight. The information that we've been bombarded with for so long, the fog that we're walking through, is not going to, you just don't get one training, then all of a sudden everything is going to, come back and we have equity. It's something that you need to continuously seek out. There's several books, on the subject, but we also, knowing that, have made several like parts to training so that it goes throughout the year. We also give people the chance to interact and speak and engage. That does a couple of things. One, by allowing people of color to tell their story, that's very healing, especially telling their story without any judgment and any shame, and just allowing you to speak is healing. And it's also really good to be able to talk to people and just get different perspectives. Maybe you can learn something that you hadn't heard of before, and that happens a lot of times. Just again, people just really don't know, what's going on. Also, though, is that we need we need to work on our systems, right? And if we're talking about systemic racism, we need to change the system. We need to, if I usually put up a slide that says the system's not broken, the system is made for exactly the outcomes that you're seeing. The system needs to be broken, and we need to build a new one if we want different outcomes. So what I've done with that is I've started to develop and implement a program for medical providers in particular to help them look internally at their systems and ask themselves the question, not if our systems is racist, but how are our systems racist? Where do we need to go back and make adjustments and changes? And really, it's very personalized, because I think every clinic in some degree has its nuances. And those, the answers to that question really comes from your staff. And so so with this program, I still work with the GEAR format or framework, of normalize, organize, and operationalize, by giving the trainings to normalize, by organizing the staff, and by operationalizing, looking at your policies and your procedures and going back through it with a tool called the equity tool. And this equity tool helps you it's just a series of questions that you go through, looking at policies and procedures to see where where you are being racist in your systems, so that you can start to build change. So I also try, again, tying this back to ACEs, is to lead with like a trauma-informed, universal approach, okay? So that we bring our trauma-informed, tools with us whenever we're interacting with patients. But a lot of times the trauma-informed piece of it is internalized too, because our systems have been traumatized over time. And so anytime that you're working or doing anything on trauma, if you don't inwardly look at yourself, then not only can you trigger people, but if you get triggered and you don't know how to de-escalate in yourself, then it just makes things a lot worse. So I think bringing that into the fold of like a whole program to address not only systemic racism, but also ACEs and trauma is very important. And so some things that I kind of learned and I think how we're moving forward with this is that a lot of times people will say, well, you need to have leadership on board from the beginning. And although that would be great, that's not always the case. And I don't think it's always needed. For example, in the county, in my county, in Solano County, it started with a groundswell of employees and staff saying, hey, we need to do something here. We don't like how we're being treated in the workforce, and we don't like how that is being translated to our community members. And so that's how we started our race equity team, was by staff and employees. And it gained so much momentum just from the staff that leadership had to take a look at what we were doing. And now they're coming on board, and it's like it's been really like a tidal wave, you know. So I do think that leadership at some point needs to get on board, especially if you're going to have like sustainability and longevity of something, and if you're really going to make change. And also it should be a priority, but I don't think it always has to start with them. And it can start with community members, it can start with line staff, and just being able to organize and come together. Second, this has to be a priority. Again, it's not a one-off. It's not like the flavor of the summer, you know. One thing that COVID-19 did was, COVID-19 in its own is a trauma, right? But what it did was that it made things slow down, and slow down enough so that people were at home, and what were they doing? They were watching. They're watching their screens. They're watching their phones. They're watching the news. And what did we see on the news? We saw George Floyd, you know, we saw Breonna Taylor, you know, and we saw these people in front of us. Not that this was new or never happened before, right? But now it's like everyone's attention is on this. And because of that, you know, this whole equity thing has had more movement, I think, in this last few months than it has in the last few years, you know. But we have to be careful with that it's not just, you know, okay, when COVID's over, we go back to how it was. You know, I like the title of the series, the better normal, you know. I'm hoping that when COVID is, you know, is better controlled, that we have a better normal, you know, that we look at where we can make progress, and that, you know, we keep that momentum going, even though it may not be directly hitting us in our face. The other thing is that you have to start, when you start, you have to have a really solid foundation. And again, that's a lot with just education and normalizing the conversation and setting up definitions so we know what we're talking about. And then you also have to have intellectual humility and racial humility. And what I mean by that is that a lot of things, when you go through these type of trainings, may be new information for some, and it may be very shocking and may really kind of make you question your belief systems and your values. And that can be troubling for people. And so it can also be very uncomfortable. You know, race is not a very easy thing to talk about for a lot of people, and it just evokes so much different emotions, and it's complex. And so, but when you have intellectual humility and racial humility, it's going in there knowing that you don't know everything, and that maybe what you do know isn't, you know, the actual truth of what's happening. And so you just, whenever you feel that moment of being uncomfortable, or even anger as an emotion that kind of bubbles up to the surface, right? And that's for anybody. Is to sit with that anger or that uncomfortableness, and don't immediately make a judgment. You know, just listen to what the person has to say and let it process. And that's where you really find change. You know, it's good to have some friction sometimes, because without that friction, you're not going to change. If you came to a race equity training and you didn't feel a little bit uncomfortable, then probably we didn't do our job, okay? Because it needs to be, you need to have some level of uncomfortableness in order to change.
Hi, Dr. Fuller.
Yeah.
We have one more guest, so.
Okay. I didn't see the mark, I didn't see the finger.
Yeah, well, you know what? I have to say that I was like, I didn't want to interrupt you because everything you were saying was so fabulous. And I thought, well, let me just like let her say one more thing.
Oh, sorry.
But anyway, this is great. And I know like a lot of people are very interested in finding out more. I know in the article I wrote that I put the link in the chat to, Dr. Fuller has graciously allowed people to write her and her email address to inquire more about the training. So I can put that, is it okay to put that in the chat, Dr. Fuller, or should we just?
Definitely.
Okay, maybe, will you do that? Because I want to make sure that's right.
Yeah,
okay,
I'll do it right now.
Great.
Sorry about that.
That's all right. No, it's all good. It's all good. I'm just, you know, it's hard for me to interrupt sometimes, especially when, you're all saying really good stuff.
I feel like I could listen to each one of you speak for hours and hours, and this is so valuable. And from the comments, everyone's getting so much value. I actually think if we can coordinate it, we should absolutely have a follow-up where,
I agree.
because I don't think we won't be able to get to people's discussion questions in this one because we still have one more speaker who I'm really looking forward to, but oh my gosh, I would love to hear from everyone again. But anyway, Laurie.
Yeah, well, I wanted to say just quickly is that, you brought up the training and how it needs to be sustainable, and that it's not something that happens in a minute. It has to be a continuing process. And we're very lucky because Ingrid Cockhren has actually led our staff internally on going through, like we started with the implicit bias, but we have these weekly meetings that we've been doing for a year now and will continue to do. And in fact, I wanted to say, and I will give more information at the end, we're actually going to have a better normal meeting about our internal process and what we're doing along these lines, because we're right in the midst of it. And, going through the uncomfortable moments and trying to figure this all out. So we'll invite you all to participate in that as well. But I wanted to introduce our next speaker, and I'm very excited. I was, looking around for the community voice, which is so important in anything that has to do with, medicine, is like hearing community voice, having community input. And so I reached out to the JPB Network on Toxic Stress because I knew they had a community leadership council that's very involved in all their research, to get feedback and weigh in. And so Cerella Craig, who is our next speaker, she's a research assistant at the Health Justice Lab at the Yale School of Medicine and is currently pursuing a master's degree in public health at Southern Connecticut State University. She also serves on the Community Leadership Council for the JPB Research Network on Toxic Stress. And so she's going to be talking about what it takes to integrate the voices of the community into medical system practices and what it takes to ensure equity.
Good afternoon, everyone. I just want to echo, what everyone said. Dr. Fuller, I could have continued to listen to you talk about health equity because I really, really, believe it is important. So a little about myself. I am a mom of 2 girls, so you may hear them. But, ever since I joined the workforce in 2009 after graduating from the University of Connecticut, I've worked in programs that brought health promotion directly into communities that need the most and really could benefit the most from that health education and health promotion. And what I would say is it's very important to bring this information into the under-resourced and what I would say are under-prioritized communities. But where I really get my joy in the work is being able to bring the community voice back to the researchers and back to the physicians and the folks who are actually developing a lot of these interventions. So that's, part of my job as an RA, and it's what I feel is really the most rewarding and what is really a way to move the needle when we talk about racial equity. I don't know how, we can really achieve racial equity if we're not hearing the voices of those who we hope to serve. And then also if they're not hearing the messages that, that the doctors are giving, that the scientific community have to contribute. The reality is that there are some really hopeful and really promising interventions and health education information out there. But we've discussed this. Bridges have been broken within the community. Trust has been, really disrupted. And so that skepticism is there, and very understandably so. So that's kind of where our work comes in at the JPB network. So myself and other community leaders, we're really focused on bridging this gap and bringing the community voice to the decision-making table. And, that's what myself and others at the network who are a part of the Community Leadership Council that's where we really come in. Just to give a little background on the study, what the network is aiming to do, so they're conducting a study and collecting biological samples from children at pediatric visits. And the goal is to be able to measure indicators of toxic stress and to eventually be able to look at change over time and see if these indicators, if there are interventions that are effective in reducing some of these effects of toxic stress and whether that can be measured in these biological markers. So although we are including different races, all races, all classes, all genders in this research, there are certain populations and communities that really have a lot to lose if we don't do this right. And I would say who, have a lot more to lose than other communities if we don't do this work with health equity at the forefront. I've been working with this group for about 5 years now. And, I think they're a very well-intentioned group. I have faith in them and in the research and in their intentions, but despite the best intentions, I think we have to acknowledge that there are communities that could really suffer, particularly Black and Brown communities, families with Child Protective Services involvement. There are communities that as I mentioned, can really suffer if this work isn't done in a way that respects them, that integrates their needs and voices, and that also understands culture. Again, where we come in, we're a group of individuals with lived experience of some of the mistreatment that's occurred in medicine. We are also working with families who have these similar experiences, and we use our voice to hopefully prevent some of these unintended consequences. The harm isn't always as blatant as what was done in the Tuskegee syphilis experiment. Sometimes the harm is unintended, but for that reason, I think it's very important to have those gatekeepers who are looking at these interventions and ideas from a different perspective, and able to give insight that could be easily missed, but very detrimental if it's overlooked. A few things that I think have been really critical in how we've tried to put equity at the forefront of the research at the network. As I mentioned, we have the community voice at every step of the process. So myself and my fellow community leaders, we've been involved from planning to implementation to updates. And not only are we at the table, our voices are heard. So we can see where our ideas have been integrated into policies and procedures, because it's not just enough to, be able to check off, yes, there were community members there. We actually have input and how things are done. And I think that's very important. So, and for that to be done at every level. Another thing our group has been able to do is carefully examine the language that's being used to communicate to research participants in this study, especially the materials that are going directly to families. We had a very interesting focus group where we were able to bring families in and present them with some of the materials. And a piece of feedback that we got was that, the way we were describing toxic stress, it made parents feel like they had damaged their children. And that once these, indicators showed up in their children's DNA, that was it. It was irreversible, the damage was done. So if you can imagine the fear that a parent with CPS involvement might have, thinking that this indicator can show, that I've done something wrong to my child. We were able to get that feedback from families and then go back and change the language, get input on the language, and to present it in a way that families did not receive it, because obviously that wasn't our intention. So we were able to go back to the drawing board and, restructure the language in a way that made families feel not like they weren't being judged. It made them feel safe. It gave them a better understanding of toxic stress. And, you know, I thought that having them at the table, had we not done that, that could have been, you know, a huge misstep. Another interesting point we got to in the study was the challenge of collecting hair samples from children, particularly from Black children. And had I known how much hair they wanted to collect, I could have told them early on that wasn't gonna fly. But, you know, when we were hearing the updates, the researchers talked about how they were having trouble collecting hair from that particular cohort. And what that allowed was for a member of the team who is an African-American woman to give a brief history lesson to some of the non-white researchers about the importance of hair in the Black community and the significance of the first haircut, particularly for Black boys. So the hope is, you know, that that's going to inform the policies and procedures moving forward, and not just for that group, but as those researchers then go to develop other, you know, protocols and to just really inform how culture needs to be a part of the discussions. So, you know, I really think that's one of the main reasons it's important to have representation. It's important to have people with different life experiences and perspectives and cultural beliefs. I think that when you incorporate those things and when you include voices of the community you wish to serve, you can, to the best of your ability, avoid these unintended consequences. You can help to develop effective communication strategies, and then you can make sure that you're respecting people and making them feel making them see that you are taking careful consideration when it comes to culture and cultural practices that are important to them. I think once, you know, these things are integrated, I'm not going to ring the bell and say we've been completely successful in this yet. There's still a ways to go, but I think some of what we've done is a starting point. And I think, you know, once you do some of these things, you really open up the door for trust. And in our case, it's a research study, but this also applies to patients. So particularly those who are at high risk, when you open the door for trust and you show them that you value their perspective and you care enough to include them in these decisions that impact their health and the services they receive, I think, you know, then communities are more willing to listen to what the doctor has to say, or, you know, to hear about this new advance in medicine that might actually be very helpful. But if that door is closed, you don't even get the opportunity for the community to hear you or for them to be heard. I think that's especially important, you know, with this screening, although it's voluntary. You know, the hope is that families will be able to see the benefit of, you know, how screenings such as ACEs might help in the long run. Just when it comes to health equity in general, I think if we intend to reach a state of health equity, then we have to be able to move the needle on health outcomes for some of the highest risk populations. But those are the ones that are most frequently isolated. And those are the voices that aren't typically heard. So, you know, again, just to reiterate, I think that the starting point is to bring them to every table where decisions are being made about their health. You know, it's never going to feel good to feel that you were the last to be informed about something that involves you. So I think that, you know, some of those things are key. And, you know, I appreciate being able to share some of our practices with you all today. Thank you.
Thank you so much, Cerella. Well, this is what I want to say. We have like 1 minute left. We could go another 10 minutes, or we can schedule another one. And I guess I would have to see everybody's availability so there could actually be a conversation based on this, because there were so many comments that came up. it seems it's not like a one-off thing, but we can, we can look into doing that if people would be interested. But I do want to, I want to just give a heads up for a couple of the other Better Normal sessions that are coming up just around the corner that are related to this. And hold on, I'm getting my sheet up that just disappeared, so I'll tell you in a second. Sorry, wait a minute.
Do you want me to grab them?
Sure, that'd be great. Yeah, so there was the one by, like, Ingrid, you're leading one on equity in the ACEs movement.
We can have, Ingrid, do you want to just say a couple sentences about that one coming up, and I'll find the link and drop it in the chat for people to register.
Yeah, I'm going to have one on October 20th. It's going to be myself and a consultant, an equity consultant here in Nashville, Tennessee by the name of Kia Jarman, and we're going to talk about equity within the ACEs movement in general. And so looking at how our movements are the leadership within our movements diverse? Are the steering committees within our movements diverse? And then also, are we reaching every group within our communities as well? So who is not being served by the ACEs movement? And just the way that we have not really centered racial trauma and historical trauma within the ACEs movement thus far, and how will we incorporate that moving forward?
Okay, and then there are a couple, thank you so much, Ingrid. And there were a couple others that are pertinent to our conversation today. One is Real Talk with Raphael. That will be one that's coming up. And then also the one that Danielle Prince, our colleague, is going to be leading on what I had mentioned earlier, which is what we at ACEs Connection have been doing, our whole internal process and what that experience has been like. Do you have, Allison, do you have those dates in front of you?
Yeah, I don't have a registration link yet for Danielle's, but I did just put the links in for Ingrid's and Raphael's. I hope that that you will join for both of those. Raphael's is this Friday at noon Pacific time, 3 p.m. Eastern time. And Raphael is a person of Indigenous Mexican heritage, and he's going to be talking about some of his experience, personal experiences, as identifying as a person of color in the United States. So I really hope that you all will tune in for that one. For the one that Danielle is hosting on the 27th, I don't have a registration link for that one up yet, but since you all registered for this event, you will be getting a follow-up email with links for our future events. So please just stay on the lookout for upcoming programs.
Well, so I just want to thank all of our panelists. This has been amazing discussion and the beginning of something I think should continue. And I will go over the chat and look at everything, and we will also send out the slides to you, and appreciate everyone's time. And I'll be in touch with all the panelists to see what your schedules are like, if we want to have a conversation with the larger group. Thank you so much, everybody. Thanks, Allison, for doing all the technical work. And I appreciate my colleagues who've been on the call too. I see Gail Kennedy, I see Erin Clemmer, I see Danielle Prince now there.
Jenna's here, yeah.
Carrie Sipp, and yeah. Ingrid, and yeah, you could call out who else is on, because I can't see everybody. But thanks, everyone.
I just want to prompt everyone to go ahead and save the chat if you're wanting to do that. So just click on the 3 little buttons in the chat and then save chat. And I'll just give you a couple seconds. Laurie, this was fabulous. Thank you so, so much. I can't wait to schedule a follow-up so that we can have a discussion. I really want to work to make that happen, because I learned so much from each and every one of you as speakers, and this is something that we need to continue to discuss.
Thank you, everybody.
All right, I hope to see you all Thursday for Education Upended with Laura, and I hope to see you all Friday with Real Talk with Raphael. We have a really rich program coming up. You can always find the registration links for upcoming and better normals on our homepage, acesconnection.com, and you just go over to the right-hand side and scroll down about halfway down the page where it says upcoming webinars, and the registration links will be there. So thank you all so much for joining. This will be posted to our YouTube channel by the end of the day, and hope to see you again next time.
Thank you so much. Thanks, Allison.